Good afternoon. I'm bringing home the sixth pillar of lifestyle medicine, which the American College of Lifestyle Medicine focused on social connectivity and positive social connections. And I'm going to be broadening that, and I'm making the case for positive psychology being part of that sixth pillar. Just a teeny bit about my background. I have a background in internal medicine, preventive medicine, lifestyle medicine. I also completed a consultation liaison psychiatry fellowship. So I've been thinking about these kinds of topics for many years. But what really spurred the passion in me was a couple of years ago when I was sitting in an audience of about 2,500 stellar researchers and implementers of positive psychology at the International Positive Psychology Association biannual conference in Montreal. And what they were talking about was really about healthy lifestyles. There were also lectures there about the microbiome, about telomeres, about neuroplasticity, and all coming back to health behaviors and healthy lifestyles. And I looked around that room and found none of my lifestyle medicine colleagues there, and or other primary care physicians, or physicians per se. They were mostly psychologists. And I realized that that was going to be my mission, is to bring together that wonderful body of research and work that's so relevant to what we do, to actually make it relevant and important to what we do. And so I convened a summit last year where we huddled, invitation only, to figure out what this all means to lifestyle medicine, primary care and other specialties, and how can we make it practical, what are the research questions. Since then, we've published a couple papers, and we've also edited a book that's really trying to make it practical. So lots to share, and I'll try to keep this short, but that's my background and why I'm standing here talking on this topic. Oh, and by the way, then I ended up becoming, when you're loud, I became the president of the Positive Health and Wellness Division for the International Positive Psychology Association. So I'm going to wrap up a little bit with what we know as current knowledge, and I'm going to say that what I'm talking about is research-informed rather than evidence-based. And it is our task collectively, and the big research question is how to make what we know in the psychology world and the behavioral health psychiatry world relevant to primary care, relevant to lifestyle medicine, and also to show those outcomes and build the evidence base that isn't there. So I acknowledge that out front. Again, this is research informed, but it's really good research, and certainly enough that we should be moving forward with this. So current knowledge, just little tidbits here and there. There's so much that can be shared. When we think of positive psychology, we might think of positive emotions, which is more the amygdala, and we'll talk about that. But we also can think about prefrontal cortex processing and our own assessment of our well-being, subjective well-being. And interestingly enough, it's that subjective well-being, if we evaluate our life as being satisfactory, meaningful, joyful, that is correlated with longevity. Now, that is, of course, relevant, as in lifestyle medicine, we're looking for longevity, but we're also looking for healthy longevity. So positive emotion is relevant to lifestyle medicine and everything we do because it is a key driver to health behavior change. We work so hard to make those behavior changes with our patients in every pillar across the board that we've been talking about today. But what really spurred the light bulb for me, and why this was so crucial for us to pay attention to in lifestyle medicine, where we are so dependent on health behavior change, is that positive emotion can actually be an unconscious driver, an unconscious motive for healthy behaviors. And there's some very interesting research around that. And clearly we need more research about it, but if we can make it easier to change people's behaviors, boy, I'm all over that. Right? And so this is a graphic from Barbara Fredrickson and her team. Actually, the paper was, leading author was Van Capellen, that shows whoops, I guess it's not going to have the little. So positive affect can drive behavior at an unconscious, non-conscious level. And engaging in those behaviors, healthy behaviors, drives positive affect, so there's that inner circle. And then on top of that, as we have those positive behaviors and reap those benefits, we're building the outer circle of what Barbara Fredrickson calls the vantage resources. So if we're a happier person, we'll probably end up having more friends. People want to hang out with us. So then that reinforces, that's an outer vantage resource that builds on itself. So a very important cycle for what she calls upward spiral theory of lifestyle change. I'm only going to talk about a few positive psychology studies, and then I'm going to dive into, since I was asked mostly to concentrate on the social connectivity. What we do know is that happiness is not just a random thing, or again, we need terminology, we need metrics. I'm saying happiness, it could be joy. Barry used the word flourish, which is a lovely word, emotional well-being, emotional hygiene. We have a long ways to go to figure out, especially for research purposes, what language we should be speaking. But regardless of the term, we know that we can intentionally boost that state. And we can do that through what the positive psychology researchers are calling positive psychology interventions. And in meta-analysis by Hendricks, it shows that combined, even if they're messy interventions, overall we can boost that subjective well-being level and psychological well-being level. And then through the logic model, we can infer perhaps that then impacts health and longevity. But again, we have some research to do there. Some of the positive activities that are in this realm of positive psychology interventions that have been really highlighted include gratitude, acts of kindness, activities that we find meaningful and purposeful. And there's a lot of research that, particularly around the gratitude and meaning, that shows a powerful connection between that and health and physical health. And even with purpose and meaning, studies that show increased use in preventive services and a lower mortality risk, especially cardiovascular disease risk. So that's just a little snippet of positive psychology. And my argument is that that sixth pillar of lifestyle medicine should really be PERMA. Marty Seligman, who wrote the book Flourish, is considered the father of positive psychology, has this nice framework: P for positive emotion, E for engagement, R for relationships, so the social connectivity is definitely there, M for meaning, and A for a sense of accomplishment and achievement. That is the sixth pillar, the five pillars, sub-pillars of the sixth pillar of lifestyle medicine. So let's focus a little bit on the R, the relationships. Lots of studies around this. The number and the quality of relationships is shown to be important to well-being. And then the opposite then, social isolation has been shown to be associated with poor health. And of course, we've seen headlines that the next wave of a public health crisis is around social isolation, and particularly in the elderly. And also, we've been talking about substance use and other aspects of what I would call, and even chronic diseases in general, are diseases of despair. And diseases of despair is different than dealing with mental illness. It's different than dealing with anxiety, depression, or stress. It's a deficit of, or a lack of belonging to a tribe, and a lack of meaning in life. And we are treating diseases of despair in lifestyle medicine, and we've got to figure out how to get people out of those diseases of despair. Particularly that social isolation piece is associated with all-cause mortality, increased morbidity, lower immune function, cognitive decline, and so on. And there are different ways that one could say that they are socially isolated. It could be by living alone, having a small social network, having few social activities, just feeling a lack of support, just feeling lonely. And we're going to need to tease that out. That's going to be one of my major questions, is that is a complicated question about which of those pieces really impacts health and well-being. There have been some lovely cohort studies, just a few here, the Alameda cohort study that showed, or at least over the 17-year period, that those who had the closest social ties as well as healthy behaviors lived the longest, so it's that combination. The Rosetto, Pennsylvania study showed that those who had high risk factors and very close social ties did much better than those who had the exact same physical risk factors but very few social ties. So there's something very protective about having social ties, and it's part of our healthy lifestyle prescription, I would think. The ongoing Harvard study on adult development, now more than 80 years, I think 85 years, has been able to collect psychological data, physical data over all those decades, and been able to tease out many confounding variables. And even teasing most of those confounding variables out, what floats to the top as a predictor of health and well-being and longevity has to do with social connection. At a minimum, having one close social connection makes a difference. So then the question is, oh, and I should say, of course, we've got the blue zones, right? Dan Buettner, he has isolated in the blue zones, where they're the highest percentage of centenarians, a number of factors. But if you actually talk to Dan, he'll say it's beans and buddies, right, the two Bs. So that's also another way that we've been able to show about the importance of social connectivity. So then what are those mechanisms of action? There are a lot of studies, there are a lot of theories. We still have a long ways to go to figure out what is that special active ingredient of social connection that makes it such a healthy habit. I showed you the upward spiral of lifestyle change, so it certainly affects health behaviors, it affects the immune system, it affects the endocrine system. I won't go through all that in deep because of the sake of time. And we've been talking about the parasympathetic nervous system, absolutely. And so the opposite of fight or flight is tend and befriend. We need more tend and befriend. What's interesting, though, is that Barbara Fredrickson has been able to show, and some other researchers have been able to show, that it's not just about intimate connections. Because people will say, well, what about somebody who just doesn't have doesn't have a life partner, doesn't have kids, doesn't have anyone? They may be able to derive the same benefit from what we call weak social ties. So it could even be those micro moments of connection that one has throughout the day, even with strangers, as long as they're authentic micro moments of connection. A nice hello to someone at the cashier desk, and someone you may be crossing the street with, and you say hello. That we have hundreds of those opportunities and moments throughout the day, each of us, and that we can boost our own well-being by connecting. Barbara Fredrickson has done some incredible research around this. She calls this positivity resonance, and positivity resonance improves vagal tone, improves heart rate variability, among other physiologic factors. Again, we have a lot more to learn about that. We've been talking about meditation and mindfulness. Her seminal work, Barbara Fredrickson's seminal work, had to do with loving kindness meditation. Out of all the various kinds of meditation, that is the most powerful in terms of impacting the parasympathetic nervous system and getting these beautiful physiologic health benefits. It's been mentioned about social networks, and Fowler and Christakis, of course, were known. They did that wonderful New England Journal article around obesity and the spread of obesity. Fowler was the lead author of another article that showed about the spread of happiness through social networks. So a part of this mechanism of action and how we address this, we need to be thinking about social networks and need to study social networks in these terms of happiness and flourishing. I know Dan Buettner also subsequently published a book on the happiness blue zones, where he tried to tease out some of those components. So if you're interested, that's an interesting reference. So what I did was I borrowed Ava's slide, thank you, and added to it. So she showed you from the stress perspective, the stress management perspective, how we go from treatment approaches to states of being the proximal outcome to the distal outcome of health. And so I complicated it a little bit because it is messy. I think what we do with stress management, et cetera, and positive psychology and social connectivity overlap. It's not clean, and actually probably in this little model, it should be even more overlap. Clearly, mind-body therapies are a kind of a positive psychology intervention. But positive psychology adds more to it. Again, the PERMA model that I've been talking about. We've also been talking about empathy and connecting with others, connecting as physicians and health providers is a component of that. That's what I was just talking about with positivity resonance as well. So all of those could be considered treatment approaches. And I've been thinking quite seriously over the last couple of years, how then can we prescribe this, and how can we make this relevant and practical for busy practitioners? I have come up with a few solutions, but we have a long ways to go. But ultimately, all of those treatments lead to those physiologic effects, as just mentioned, and throughout the day, as we've been talking about the parasympathetic nervous system versus sympathetic nervous system versus telomeres, microbiome, you name it. It's all in that middle box that ends up with resiliency and what I'm calling total well-being. Again, terminology, nomenclature is problematic here, but in my mind I had to come up with something, and total well-being, and I think lifestyle medicine is all about advancing and facilitating total well-being, is improving physical health, mental health, emotional health, social health, and this other piece that Martin Seligman coined as positive health, and he says that adds as an independent factor to health and well-being over and above all these other types of health. And that's lovely. Again, it raises a lot of questions, more questions than answers, but absolutely we need to be thinking about it, and especially as we're thinking about research for our field. So that is a nice segue to what are some of those questions. And there are basic science questions, clinical treatment questions, as well as population level questions. These are just big picture questions. Mostly on the basic science side is what is the biology and physiology underlying positive psychology interventions and social connectivity. We really need to build on Barbara Fredrickson's work and what she's shown through those micro moments of connectivity and impact on vagal tone, etc. Also, it's very important to remember that positive psychology, it is a sixth pillar of lifestyle medicine, but it is also the foundation of every pillar of lifestyle medicine, so it's great that it come last because it impacts health behavior, but not only that, but it has a reinforcing and reciprocal link. Every pillar has a reinforcing and reciprocal link with emotions, positive emotions and emotional well-being. So we know that a plant-based diet boosts mood. Happier people are more likely to reach for the apple than the chocolate cake. We know certainly there's a ton of data around physical activity and mood and vice versa. Sleep, substances, again, substance use and suicide, those diseases of despair, there's a reciprocal relationship. Stress, and what we need to do is be able to tease out the mechanism. So what's different about a plant-based diet versus physical activity in terms of its mechanism of action to boost mood and vice versa? So again, perhaps some of this may be in some of the mechanisms we're talking about with modeling and biobanks, et cetera. So this is some big basic science questions. Some big clinical research questions are, well, then we really care about outcomes. So what are the physiologic, neurologic, psychological outcomes of these positive psychology interventions? Can we really reproduce this upward spiral, the theory of lifestyle change, in a traditional healthcare setting, or certainly in a lifestyle medicine setting? And then if we're able to be successful with building healthy lifestyles with our patients, how can we boost, how do those more specifically boost emotional well-being, mental health, etc.? And at the population level, of course, our patients live in communities. What kind of community environments support this kind of positive psychology? What kind of public health interventions and environments can help us as we nudge our patients to live a healthy lifestyle towards total well-being, and we send them off from our office to the community where they're spending most of their time? How can that community be supportive in a way that would be in tune with what we're learning from the field of positive psychology? The next couple of slides are more specific examples, and I'll just pick a couple here and there of research questions. One that I think is pretty exciting is around hope therapy. So remember, I was saying that some of these feelings, emotions are not random. We can create those emotions, and one of them is a sense of hope. So there is such a thing as hope therapy, and there's some amazing science going on around hope therapy. So how is that relevant to lifestyle medicine? Can we prescribe and offer hope therapy in a lifestyle medicine clinic? These are interesting questions that we need to address. The whole piece about empathy in clinical encounters is very interesting. In 2011, there was a great study that showed that patients who rate their physicians as being more empathetic, these were patients with diabetes, had better hemoglobin A1Cs. And just earlier this year, there was a study by Chaitov that refuted that. And of course, this is the whole era of non-replication of studies, et cetera. I don't know. We need to look at that further. I can't imagine, with all the data that we have from Barbara Fredrickson and others around positivity resonance and social connectivity, that empathy in the clinical encounter doesn't do something. So we need to look at that, and that should be, again, part of our total lifestyle prescription, is that we as physicians and the health team are part of the treatment. Our connection with our patients is part of the treatment. There are questions about, then we talked about sort of precision medicine throughout the day. We know that different activities may work differently, or we conjecture differently with different patients. So we need a person-activity fit. How do we figure that out? What is the optimal, quote, dose of a particular positive psychology intervention? So Sonia Lubomirsky at the University of Irvine has been doing some amazing work about gratitude dosing. So asking a patient to sit down and think about 3 good things every night may be too much. That may backfire. Maybe the optimal dose is once a week, where it's more genuine and you have time to reflect, rather than here I go again, okay, what was good about today, as we're rolling our eyes, at least in our heads. Refining this research is really important. There is also nuances of affect that's really important. It's interesting, we've been talking about meditation and stress management and how that has a calming effect, and that absolutely has an immune effect, and it improves various disease states. But some of the positive psychology researchers are showing that perhaps words that patients use, such as calm, are not necessarily associated with longevity. Is that true? Why is that? It's the words that are more high energy, like excited or I'm feeling vital. Those are associated with longevity. So the nuances of affect is just beginning to be unveiled, and there's some wonderful work. One of the leading researchers is Sarah Pressman. If you're interested in this topic at all, she's just doing some amazing studies. Again, what is the active ingredient in social connectedness? How do we tease out social isolation versus feelings of loneliness? And as older people, as people age and they lose friends and relatives, they adjust mentally to having fewer people in their social networks, and they tend to do okay. So is there a way that we can prescribe for people who have smaller social networks a way to adjust, maybe a cognitive behavioral retraining, so that they don't have the bodily effects of what we might consider social isolation? Of course, I would be remiss without at least mentioning social media, and so much more studies to be done there. The early bird studies are showing, of course, that it's associated with, as we'd imagine, people are making comparisons. Everyone's looking happy in those Facebook posts, and you're feeling not happy, so you're comparing yourself, so it increases depression. But how can social media, which is such a reality in our lives, in everyone's lives, be used in a positive way for positive social connection, are, again, important questions of our times. Those are just a few examples. And so a summary, just a quick summary, that we need to learn more about positive psychology interventions as well as social connectivity from a basic mechanism of action perspective, as well as from a clinical intervention perspective. And that I strongly believe that the field of lifestyle medicine is in the best position to figure this out for the rest of our colleagues in healthcare, because we are so dependent on health behavior change, and this connection of positive emotion and health behavior is so important to us. And because everything that we do in lifestyle medicine, every pillar, does boost flourishing, does boost emotional well-being, and that if we can also focus on emotional well-being, that's going to make our jobs easier to help with health behaviors. It's that reciprocal reinforcing relationship that puts us and our field in a prime position to advance this whole area of science for all of healthcare.
Thank you, Mike, and thank you, Liana. I'm rather left to infer that Mike's principal reason for putting me on this panel was that he wanted to embarrass me in public. I'm trying to remember what I ever did to him to justify that. Because Liana was quite correct when she told me earlier, I'm really not sure why you're on this panel. I think you should just say what she said. So, what she said. And in terms of the expanse covered, I agree entirely, and I agree emphatically, and not only a lovely job covering the case for an emphasis on social connection and positive psychology, but frankly, upliftingly delivered, right? A lot of positive energy in Liana's delivery, and I very much appreciated that. In the couple of minutes that I have to try and contribute something beyond what she said, I offer reflections at the confluence of evidence, ethics, empathy, and urgency. I ran into Neil Barnard down in the lobby. I was coming back. Actually, after the physical activity talk, I took a break and went to the gym. At least it shows I'm paying attention. But I came back. Neil was in the lobby waiting for an Uber driver on his way to the airport. He leaves for a conference in Saudi Arabia tomorrow. And it was the first opportunity we had today to really interact, other than a quick hello. And he asked me, how are you? How are you doing? How's it going? And I said, fine. And I asked him the obvious question, how are you doing? How's it going? And he said something like fine, but after a pregnant pause. And I said, and so, really? And we then had an exchange that was a bit more meaningful than how are you fine, how am I fine, okay, great, back to business. In fact, neither of us is entirely fine, because both of us are caught up in a war. More often than not, we feel that we're losing. A war about truth, a war about what matters, a war about the plight of not just people, but the planet, and it's exhausting. And frankly, we're both exhausted, and we admitted that to one another, and perhaps that was the positive psychological boost of that encounter. But I'm left to wonder on the topic of empathy. We read so much about burnout in the clinical professions. Are we, in fact, in the stresses we confront, in the mechanisms we build, in the demands we impose, undermining the very attribute and aptitude on which we rely to pay forward positive psychology. Now, if those of us who have been committed our entire careers to adding years to lives and life to years are beaten up and exhausted, does that degrade empathy at its origins? And must we then link the focus on treating burnout and cultivating not just empathy, but optimism, so that those can be paid forward? On the topic of evidence, as Mike mentions, I'll address that this evening. It is interesting to me that that's come up in almost all of the sessions throughout the day, and I humbly submit we are being bullied. There is not just one way of knowing. There is not just one way of understanding, and most of what humans understand about what's true and that matters most in the world does not emanate from randomized controlled trials, but we'll get into those details this evening. My particular concern in the immediate aftermath of a talk about dual topics, social connections and positive psychology, is that we live in a world where social connections are propagating negative psychology. So Liana threw in at the very end the reference to social media. We have some understanding of mechanisms here. The book Going to Extremes by Thaler and Sunstein talks about how people get radicalized. They actually explore the issues of terrorism, but they note that internet echo chambers create the opportunity to radicalize everybody about everything. And then that creates the balkanization that was referred to earlier today with regard to diet. And I often fear that simply by representing truth and evidence in the realm of diet, somebody is going to attack me with a food I'm saying people should not eat. Right? So I'll be clubbed over the head with the leg of some animal I'm telling people they should not be eating or something. But the tribalism is extreme. So the polarization that really is baked into our interactions with social media, that really has become a corruption of our understanding of what's true, I think is a dire threat to positive psychology. I will confess, and I was reflecting before the invitation, Mike, what exactly do I say on this topic as a member of this panel? Do I make the confession that I fear for my own positive psychology? 30 years of fighting this fight, I fear that it's harder to recognize the truth than it's ever been before. I fear that propaganda may win out over evidence. And I fear that social connections become a way for people to shop for the opinion they already own, amplify it online, and conclude that everybody else must be a moron. And you receive a talk to the hand response. And so we cultivate distrust of one another, disgust for one another, and an impasse that erodes the positive psychology of those of us who want to create healthy connections. And then that leads to my final reflection. And it connects these issues of evidence, empathy, the urgency of what's at stake here, the fate of democracies, the fate of the Amazon, the fate of the planet, the people, the burden of chronic disease, all of that's in play here. And again, I'll devote this evening's talk to matters of evidence in some detail, but here I would note that the ethics of medicine that underlie all of what we do collectively give us a mandate to act even when uncertain. In the Hippocratic Oath, in primum non nocere, and in the precautionary principle, if it's quite clear that positive psychology looks pretty good and almost can't be bad, and if it's quite clear that healthy social connections look pretty good and almost certainly can't be bad, and if we have within view a threat of negative connections and adverse psychology, we've got a choice to make. We can keep waiting on the world to change and keep waiting for the evidence to aggregate to say, okay, now we have enough randomized controlled trials and meta-analyses to make efforts to cultivate healthy connections, positive psychology, something that the House of Medicine embraces. Or we can say the precautionary principle already points clearly and righteously in the direction of doing all we can to cultivate the very attributes of which Liana spoke, because there is a clear and present danger in the other direction. Thank you.
Thank you. Thank you, Liana, and now I can say ditto to what both speakers said. Though I do want to do a joy intervention over here.
Yes. Yes, please help me.
So I'm just going to add some very brief points to really further emphasize that importance of dealing with physician burnout. Here at UPMC, we're actually very fortunate. Jennifer Berliner just walked in, and she's actually leading the charge in initiatives to help with our physician burnout here in this system. So something our system is taking very seriously. I think that one of the areas that I think would be helpful as we're thinking about the areas for the white paper is, where does positive psychology end and mind-body interventions begin? I think we sometimes falsely dichotomize those when in fact there's an extreme amount of overlap when we're talking about those interventions. I think you so eloquently talked about how just being positive itself is therapeutic, and we need to be at the clinician level. We have to think about our caregivers in our community. So again, I think looking at the layered approach out from the individual at every level, how do we bolster positive interactions and self-positivity, because that just shines. I'm very fortunate 6 days a week, whenever the river isn't frozen, I start my day rowing on one of the rivers in Pittsburgh. And so I start most days beaming, because that's sort of my gift to myself. And from 5 to 7 a.m., rarely do I get a patient call to interrupt my peaceful row. So again, I think part of the burnout is both what happens on the job, but sort of, again, what are we doing to really take the best care of ourselves? We heard, I think, in one of the earlier talks today about, peers and coaches, and I think those, cultivating that, figuring out how do we build systems that can also support others, and the social connectivity, really important social connectivity role that they serve. And then another area we haven't talked about, but it's really growing, and actually it's growing a lot in autism, in PTSD treatment, is pet therapy. And the programs actually, and seeing patients, and I have a 3-year-old Newfoundland dog who's a therapy dog in training because she hasn't passed her exam yet, but she actually comes to my private practice. On Saturdays, I work with traumatized adolescents, and just watching the connectivity and the natural intuition with which she can really bring out in kids something that no matter how great my words are or my silence, I can't do. And I think, how can we take better advantage of that? And then the last area that I think would be so important for us to embrace as an area of focus is homelessness. So I think there's still so much homelessness out there, and when you're homeless, you're not going to have the social connection ability, and everything else spirals in the wrong direction. So thank you.
Great. Marcel has worn many hats. He's now at the National Institute on Aging. But I thought particularly...
Let me cut you off right there.
There you go.
David has warned me that you're trying to insult me.
That's right.
Yeah,
But
we know your game now, Mike.
Yeah, we were on to you. But Marcel, please, from
Introduce
all the
myself.
perspectives you have.
Yeah, I'm Marcel Salive from the government, and I'm here to help you. So I'm from the National Institute on Aging in Bethesda, not Washington today. And I have a background in preventive medicine and 15 years at NIA, and did some work with Medicare during the middle of that on some expansion of preventive service coverage. So I don't have a lot to add. I think the panel has given a great list of topics. I think, the Aging Institute is your friend, and we cover many of these areas, I think, and fund topics in this area. I think the key thing about NIH to remember is just that most of the institutes have a broad array of interests, despite their names, and most of the science is done, I think, by multidisciplinary teams now, so you need to reflect that. We've heard great talks about well-being, which I think is under-recognized, even though we are the National Institutes of Health. And so, I just have a few comments of think very big, think big on this, because I think you've heard a lot of great ideas for research projects, but need to think big. We heard a good example of one big project NIH is funding, the Motor Pack project from earlier today on kind of, what's really going on in the muscle. That's the kind of thing NIH can do. But I think there's some very relevant other ones that come to mind. For this topic today, this talk, OpNet is something that is an NIH project which is dealing with, what is really going on in positive psychology. What is going on there that under, the basic mechanism that makes this beneficial, besides the mental health benefits, but at other levels. We have the Toolbox project has dealing with measuring social connectedness, and I think there are some tools there in that kit that can be used. The Promise initiative dealt with a lot of different measures of symptoms, positive affect, sleep. Really, there's a lot of well-developed, non-proprietary measures there that can be used. So, let's see. I think someone commented that social connectors were not recognized by the healthcare system, but I think they are at the two age ends of the age spectrum, and I just wanted to point that out. Children and their parents are certainly, I think, well dealt with, and older adults and the caregiver is becoming more of an issue. I think that people who don't have a caregiver, that's very much of a problem, which I think was just pointed out. But there's certainly some recognition of it. It can get stretched through, and I think those of us who are, I guess, middle-aged men like Mike and myself, I'm middle-aged anyway, need more social supports. Is that my wrap it up time? I think the big thing I would also mention is large prevention trials can be funded by NIH, and but they are hard, they're a challenge, and you need to build a coalition, do it right, and I think that will help quite a bit. And finally, I guess I will agree with David Katz that the evidence is becoming kind of a cudgel, but I think, and if you look at even the cardiology guidelines, since we have some cardiologists in the room, most, truthful looks at those guidelines, which are among the most evidence-based, highest rigorous, 15% of their recommendations are based on trial evidence. And so that's not close to 100%, last I checked. So it's, and those are excellent guidelines. There's a lot of things that are not trialed and are still recommended.
Right.
And so I concur heartily with that. Thanks.
Great. So we have some comments or questions on positive psychology, social connectedness for the panel, for Liana.
I'll just try to talk about it. Actually, this ties to both the prior panel on, I think one of the prior panels on stress and this. So, has there been some? I think there's been some fair amount of work on pheromones or related chemicals that are essentially diffusing out into the air that we basically put out that indicate, among other things, that we're stressed or that indicate that we're happy. And I think that's an incredibly understudied phenomenon, which is that if I'm really mad and stressed and I'm standing next to you, in a little while you're going to get really mad and stressed, even if I'm not actually shouting and screaming at you. You know, it's not just my, you know, it's a sense of perception of agitation or whatever, but it can come across much more readily. And I think from what I've read, there have been some attempts to try to actually work with this, to try to create happiness in a crowd by essentially seating happy people or something in that regard, or maybe medicating people. I think that is actually potentially a very fruitful area wherein you could put a chemical or biochemical or biological basis behind social connectivity. So if I'm happy and I'm connected to you, you're happy. Now, if I'm unhappy and I spew that unhappiness out via social media, maybe I make a few million people unhappy. And the thing about it is that it's now all those people seating the people around them. And so in theory, one could imagine interventions that would be aimed at that. So I don't know if anyone has any thoughts or reactions.
I agree that it's very understudied. You know, something that I do with all my patients in my psych clinic is I try to get a spontaneous smile out of the patient. And there's not a one way to do that. And to me, that is what, for my self-grade, marks whether it was a success or not. And so I think there is something to that seating, and that it doesn't even need to be an intervention. It can just be sort of an awareness and making it sort of a conscious goal.
Okay.
Yeah,
Victoria?
there is smile therapy, there's laughter therapy, there's laughter yoga, and we've all experienced kind of contagious laughter, so that's all part of what can be used as an intervention.
So one of the things we do here, we have a modeling center, as Jorm knows, but imagine if we could model positive contagion the way we model measles epidemics or opioid use, right? Don Burke's work and others, things like that. Victoria?
So I wanted to appreciate all of the...
Sorry. David had a comment. Go ahead.
Just a quick comment, I'm sorry, if
Yeah.
I may. Your question began with pheromones and then ended with ranting and social media, which is obviously neither transmitting chemicals nor directly visible. In between, though, I think there's fertile ground for research. We know a lot about the interaction of species other than our own. And I think one of the liabilities of Homo sapien arrogance is to forget that we are animals, and we are social animals. And we can see how social animals convey emotion to one another, vividly clear among primates, frankly, quite clear among dog owners. Dogs perceive the body language of other dogs. They know if they're stressed, they know if they're nervous. You can watch two dogs go from calm to fighting in an instant because one conveyed anxiety to the other. I'm an equestrian. One of the things those of us who spend lots of time with horses know is that our emotion translates directly to these animals that are basically designed to pick up cues of danger. So, you know, as we were discussing earlier, the idea that I think Eva vividly conveyed the idea that, you know, a lot of the stress response really is about avoiding danger. Animals that live their whole experience in danger are more acutely tuned into that than we. We've long been near the top of the food chain. And so the subtle cues of how what we're feeling translate into things we don't even know we're putting on display almost certainly reverberate out around us if what is true for all these other species that have social groups is true of us. And I would say the starting point is there's no reason to think it isn't true. Those are our origins too. It was important to know how other members of your tribe were feeling to stay out of danger, right? There's a survival value in staying out of the way of the guy who's really angry today, that sort of thing. So you don't want to wait until he's hit you to realize he's angry. You want to stay out of his way by picking up subtle clues. I would agree there's rich fodder for research there, but I think there's already lots of evidence from, in particular, species other than our own.
So there's a commonality among humans and other species, but also the other opposite, the impact that we need to think about that I forgot to mention, or we were in a hurry, is that there are differences within humanity when we look at cultural differences. So we've got to study the cultural differences and the signals we send each other and what's considered positive versus negative. So just want to throw that out, sorry.
So I want to appreciate the panel. In particular, I wanted to just emphasize one point and ask a question. Liana, you mentioned that when we say calm, Calm is maybe the wrong language to use with someone who's anxious because it's at such a different valence of energy. Whereas if you can help them translate it into, I'm so excited. And that doesn't always work when someone's anxious, but sometimes it does. And the importance of us, as we think about lifestyle, to think about the language with which we convey that which we hope for people, because there's so much hexing in medicine. Maybe unintentional, but it happens that often we convey our messages negatively instead of positively. And the question I have is, you also mentioned briefly synergism. So you said in some ways positive psychology can overlay or amp up everything else that we do. And my sense in practicing integrative medicine is that there's an incredibly powerful synergism in these different areas of lifestyle, and yet at the same time, we worry about making too many recommendations or overburdening people by asking them to do too much in too many spheres. And I really believe we have to think about what research allows us to look at the synergism of addressing something from multiple different angles. And at the same time, often our funders don't want that. They want to understand the single intervention. So the question is both, how do you reflect on studying synergism, and maybe what can our funders do to help with what is truly the complexity of taking care of human beings?
Any
Wow.
comments?
I agree is mostly what I have to say there. We are complex, and especially when we get to human psychology, it's ultra complex. And then we're looking at, I'm saying total well-being, a total healthy lifestyle, which has all these activities, if you will, habits that we're asking of patients. And that is, number one, difficult to prescribe, to recommend, to facilitate the behavior change, and possibly difficult to fund. I don't know. You would think that at some point we would cross that barrier and actually look at, well, it's holistic medicine, and that term hasn't been used yet. But we are a system, a human system, a community system, a social system. So funding should be looking at all of that together, and maybe thinking in terms of systems might be a way around that.
And I think you could also almost apply an engineering mentality to it. So Liana just used the word holistic. I was going to react to synergism or synergy also with holism. So we want to fix everything. But we can't just scoop people up and take them to the ramparts of happiness and vitality. We have to figure out operationally how to get there. All right, so no skyhook. We need a spiral stair. Seems to me in an age of machine learning, artificial intelligence, and the use and leveraging of large data repositories, we have the opportunity to determine what are the key indicators of who responds best first to blank. Blank might be about relationships. It might be about stress management. It might be about diet. It might be activity. It might be sleep. It might be pain management. What indicators do we need to say, where do we start? So we don't actually try to fix everything all at once, but we become artful about sequencing. So we would leverage the positive advantage of each slight gain in altitude to achieve the next and the next with vitality at the top. And I think it really is an engineering challenge. You know, how do we sequence the interventions so that they optimally support one another without becoming overwhelming at any one time? And I think that could be converted into testable research hypotheses for which the NIH might have an appetite.
And David's leading us into the methods discussions with advanced research methodologies tomorrow. That's exactly how we're going to be focusing on it. We'll get to Stacy and Paul, and then we'll move on to the final panel of the day. Stacy.
Hi, I'm Stacy Durant. I'm Peds Cardiology at Children's Hospital. And one of the committees that I sit on at Children's is the Physician Wellbeing Committee. And so there's been a lot of emphasis on that recently. And when you were talking about the micro moments that people have that really helps, it makes me reflect on just our patient interactions and how close, I have some patients that I see once a year being a subspecialist, or once or twice a year, and how close you can get to those people just seeing them very infrequently. And so what I'm thinking is whether or not, as a research idea, whether or not training positive psychology, whether or not that could improve those micro moments, even, you know, the registration person, how well they interact with the patients, and whether that can help not only physician well-being, but also the patient satisfaction, which is also being looked at very closely. Okay, that's a lot to say. Yeah.
No, don't.
So that's a wonderful cue for me to mention that thanks to Ardmore Institute of Health, we have at the American College of Lifestyle Medicine are developing a physician and health professional well-being program that is focused on healthy lifestyles, but also on positive psychology. So that's coming soon, and I think it's going to be added value to the existing physician well-being programs because it's highlighting some of these other aspects of positive psychology that may not be highlighted in other programs.
The second point is we do need science to support this. We do need the data to support. For instance, if you look at the data on pain and mindfulness training, all meta-analyses I'm familiar with say the same thing. The quality of the research is very low. There are very few well-conducted studies, and in the end, the evidence is at best weak. That's a problem, because we cannot propagate a religion to solve a real problem. And in my perspective, it's even a bigger problem, because I believe the only way to build scalable healthcare is to rely strongly on technology. To build technology, you need well-defined specifications. Lacking specifications, you don't really know how to change your algorithms in response to this highly variable set of patient profiles you're going to encounter. So we do need to think more carefully and critically about the kind of science that we advance to back up these ideas of positive psychology and mindfulness, because right now, as far as I can tell, please correct me if I'm wrong, it's still not there. If it's not there, it's not going to fly. If it's not going to fly, it's not going to help us to improve the human condition, and that's why we're here. Thank you very much.
Yeah, I absolutely agree. That's why I started my talk with what I'm
Right.
presenting is research-informed, the research in psychology and others, and not evidence-based, and we need to build that. And because it's complicated, I didn't mention, but I should mention since you raised the question of Wally, is hedonic positive psychology versus eudaimonic positive psychology. So hedonic positive psychology is not associated with the health benefits and longevity, meaning kind of just pleasure for the sake of pleasure. Eudaimonic means pleasure that is affiliated with meaning, social connections and other activities that are meaningful, maybe a little bit stressful, but will actually have that health impact that we're looking for in longevity.
And you made a great point about stress. So I did not mean to imply stress-free. I mean, that would be imaginary. I think it's for people who have migrated to sit in a chronic stress zone that is now causing all sorts of secondary health complications. And I think one of the best physiological indicators we have of stress reactivity is heart rate variability. So we want to be able to always mount a very effective acute stress response. We just don't want to stay there for a year. So I think it's that difference, not the complete, stress-free would make life boring, I think.
So thank you very much. Well, let's have a round of applause for the panel. Tremendous.